welcome everybody. Thank you for this invitation. It's for me an honor to be here. Professor Josep, that's a big pleasure to be here. You know that our first time or contact was through a very common friend, Dr. Pomar, who is the chief of cardiac surgery in my hospital. And since that you know that he admires you and he's always explaining how you have teach him and the world about different aspects of cardiac surgery, and he's extremely rewarding to you. And when he asked me whether I would be willing to come to Doha for this meeting, obviously I was more than happy to come here, and I'm really it's really a pleasure to be here. So thank you very much for this invitation, and I hope that the next 2 days will clarify everything related to Brugada syndrome. My first talk is a talk that will basically explain a little bit how Brugada syndrome started and what do we know in Brugada syndrome and how we have evolved during all these years. So this is the slide that summarizes a little bit everything, because everything started with this young boy, 2 years of age. He had been recovered from sudden cardiac arrest, and then we learned that his sister died suddenly, and we could recover also an ECG of the sister. This was 1986. We understood nothing of that. Sister died, the brother was still alive after recovery from sudden cardiac death. They both had very strange ECG. This boy had also 6 sign syndrome. He was implanted at the time with a pacemaker, and he was giving amiodarone, and we didn't understand too much what to do and how to do it. This was 86, remember, 86, and ICD in children was even not thinkable because the size of the ICD was not possible to imagine. So, but then we will go back to this. But very interestingly, this first clinical consultation led from 86 to 92 to the publication of the paper, because other patients arrived during the meantime, and then we realized that the 2 first patients were similar to other 2 that we had in adults in the next years, and then 4 other patients. So finally in 1991 we present that in a World Congress in Washington, and then in 1992 the paper was published after a long period of training through different journals of the world that they were saying, what is that, this is not important, this is not important, what is that, what is that, what is that. And at the end it was published in JACC in 1992, because Arthur Moss, that was the editor of JACC at the time, accepted the paper. Now, in 1996 something very special occurred, is that we could, between 96 and 98, we could, through the analysis of several families, and one special family that I will also show you later, we could understand that this was a family affair, and that this was genetically driven, and that we could analyze the first mutation in the sodium channel responsible for the disease. We could analyze in oocytes that the effects of the mutation on the sodium channel, and of course the future will be, or that this is an old slide, probably we are already in the future, but still the other things in the future will happen. So let's go back to the beginning of the story. So this is Lech, that was the name of this child that has been recovered, and in 1986 was brought to us with a very special ECG, very abnormal ECG, and recovered from sudden cardiac death. In 1990 we could put together, as I was telling you, 4 other patients, all of them with this very peculiar aspect of the electrocardiogram, absolutely abnormal. Today I'm still astonished to understand, or trying to understand, how is it possible that nobody has ever seen this very abnormal ECG before? Because we have been looking at millions of ECGs in the world, all of us, and this is tremendously abnormal ECG, but nobody has paid attention to that, or nobody has made the link between this ECG and sudden death. And you see that there is this prolonged PR interval. There is this right bundle branch block. In this case, you see an S wave in 1 and in V6. So there is no doubt an R prime in V1, and this tremendous ST segment elevation, what we call now the GOV type or type 1 ECG. So, as I was telling you, the story started with the identification of this first child in 1986. We present 4 patients in 1991 in Washington, and then the article came in 1992 with in JACC with these 8 patients. This is the original article. As I was telling you, it took a long time before this article was accepted, because many editors in other journals were simply saying that what the hell are you telling us? I mean, what's that? I mean, these are simply rare ECGs, but this is nothing to do with sudden death, etc. Very interesting, in these 8 patients who already said a lot of things, and each time, so sometimes I reread the original article, and we put almost everything that later on it was confirmed, but we said a lot of lies in the title, because we say right bundle branch block, not always, sometimes yes, sometimes no. Persistent ST segment elevation, definitely not. Almost everybody has a normalization during the follow-up, and sudden cardiac death, yes, in these cases, yes, but now we know that we have a lot of asymptomatic people with syndrome, and that would never develop sudden cardiac death. So if we look at the title, we were completely lying in every single one of the sentences. So that's why probably somebody else decided to change the name of the disease and call it Brugada syndrome. So this is the first time that it was called Brugada syndrome. This was in 1996, and was Miyazaki in this article published in JACC also, that says autonomic and antiarrhythmic drug modulation of the segment elevation in patients with Brugada syndrome. That's the first time in history that the disease was called Brugada syndrome. Okay, and very interestingly, since then everybody adopted this name and everybody called that Brugada syndrome. But not only that, but the interest in the disease was dramatic, incredible. We could not ever imagine what happened in the subsequent years. This is the number of articles published per year that have in the title Brugada syndrome. We are 20 years later, and we are still publishing, or the people, the community is still publishing 250 articles every year in peer-reviewed journals that in the title use the word Brugada syndrome. Incredible, the interest on the disease. And these are the number of citations of the articles with Brugada syndrome per year. You see that we are now at 5,000 citations every year of the articles that have in the title Brugada syndrome. Why is that? Well, probably because we came at the right moment. At the right moment means that we had, at that time, we have been the electrophysiologists, we have been very hard working in research. We have been describing everything in the 80s. If you look at the largest CBs in cardiology, at that time they were all electrophysiologists. Why? Because we had everything to describe. The electrophysiology was virgin. We had to describe everything. Every single condition had to be described, so we start to understand Parkinson, white, atrial tachycardia, different types of accessory path, whatever. Everything was to describe. So we were publishing. But at a certain moment, ICDs arrive and ablation arrive. And we kill research. Because we know everything about physiology of the arrhythmias, or almost everything. The only thing it was still not known was atrial fibrillation. We used the second wave later on, 10 years later. But at that time, atrial fibrillation we were not interested. this creates strokes. We are not interested in that. We're interested in arrhythmias, And so what happened here probably is that Brugada syndrome opened a new way of looking at sudden death, at basic research. And many centers that were studying or were doing research on arrhythmias moved to the new field of genetics and arrhythmias because of Brugada syndrome. And this probably helped a lot in this huge interest on the disease, much more than the real incidence of the disease. So this is a little bit what has been published by us, by the Brugadas in Brugada syndrome. So that's the initial description in 1992, clinical description also 97, sudden death, genetics, that's the first genetics that was published in Nature in 1998, temperature dependence, the Ashmolean test, the use of electrophysiology testing, how ICDs help in the treatment, what is the risk for asymptomatics, long-term follow-up, similar of SETS and Brugada, similarities of SETS and Brugada, diagnostic criteria. This was the first joint document, mutations, risk stratification, ECG changes, second consensus document on how to manage the patients, and more mutations. So this is a little bit what we have been done over the last years, and we have to realize that when we are dealing with Brugada, we are talking about an ECG basically. So we have to make clear what do we mean by Brugada and when to make the diagnosis. And this is probably, this slide I'm showing here is one of the biggest mistakes we ever done, and was to classify Brugada in type 1, type 2, type 3, because we were not clear enough saying these are non-diagnostic electrocardiograms. And the people is still diagnosing a Brugada type 3. Brugada type 3 does not exist. This is not a Brugada, this is just a suspicious electrocardiogram, or it's just an alveolar polarization electrocardiogram. So probably we have to make sure, and we try to say it once and another, this is the only diagnostic electrocardiogram. You cannot make the diagnosis of Brugada, you should not put the word Brugada in your mouth in front of a patient if he does not have a type 1, because if you say you have a type 3 Brugada syndrome, the patient will go immediately to the internet, will type Brugada syndrome, and he will think he's going to die in the next 5 minutes. Okay? So please do not use the word Brugada syndrome unless you have a type 1 ECG, because if not, then the final result of all that is that this guy will contact me. Okay? This guy will contact me, or Pedro, or Ramon, and will ask, I'm going to die, what shall I do? Okay? So be sure that you make the right diagnosis to the patients only when they have a type 1 ECG. Now, why Brugada is interesting? Well, because they die. You see here a patient, and this was a taxi driver, not this one, but this was a taxi driver from Uruguay, from Montevideo. And this patient had a syncope and had a car accident. And then he was brought to the Hospital Español in Montevideo, where a very good friend of mine is working. And then this guy was on the emergency department, and while they were taking this electrocardiogram, bang, the guy did again another polymorphic ventricular tachycardia syncope that required resuscitation. And you see here the very clear type 1 ECG in leads V1 and V2. We understood also that the ECG was not persistent ST segment elevation, but that you have these variations in the ST segment elevation that you could modulate it by using different drugs, Ashmolean or isoproterenol. This is a patient that went to our hospital with a syncope. It was suspicion on the ECG. We did Ashmolean, and you see how nice the ECG changes and has a Brugada type 1 pattern that is normalized after isoproterenol. This is his brother that had an almost normal electrocardiogram and positive with Ashmolean that also again normalized. So this came to complicate a little bit more the story, because the ECG is changing, so it can be modulated, it can be positive or not depending on the moment and on the condition, so this creates some difficulties again in making the diagnosis. This is the most important family we ever studied. This is an Italian family, and this is the first family we ever discover a mutation in the sodium channel. This family came to Barcelona because this guy died suddenly. his twin brother was alive and all the rest of the family, but they have had a complete checkup for sports practice, both brothers. So we had all the information, and we could see that in fact, and this was in 1995, nobody have perceived that this patient had a classical Brugada ECG pattern on the ECG. So we could analyze the rest of the family, and we find now 9 patients with a spontaneous or drug-induced type 1 ECG. So we did the genetic analysis, and we could discover the first mutation. That was a mutation in the sodium channel, and this mutation was showing that it was having a loss of function in the sodium channel, and this was published in 1998 in the Nature. This is an old slide, but it shows a little bit the situation. We are discovering mutations in the sodium channel in our series in around 30% of the patients. So we are still missing 70%, and now we start understanding that the majority of genetically positive patients have mutations in the sodium channel, but also there are some mutations in potassium or in calcium channels that help us understand a little bit more the why the disease is there. So we are also understanding some features like this guy here, which has a long PR interval and a clear Brugada pattern, and this guy had, when we analyzed him genetically, he had 2 mutations. And he has inherited 1 mutation from his father, 1 mutation from his mother. And he has 2 daughters, and each one of the daughters has inherited 1 of the mutations. So you see that when you combine both mutations, you have a long PR and Brugada. When you have 1 mutation, there is nothing. When you have the other mutation, you have a long PR. So we start also understanding more and more the combination, and probably genetics is not as simple as we thought, or as we have been explaining so far. It's good to try to explain it very simple and to try to understand the features, but it's also true that the reality is much more complex than a simple mutation giving a simple disease. We know that the disease can be very, very harmful. We know that the disease can kill people, and this is again an example of a patient with a Brugada and that had different episodes of ventricular fibrillation that were all of them terminated by the ICD. All of these were initiated by the same premature bit, and at least looking at the morphology on the single channel ICD. We also know, and we have learned, that males have a much worse prognosis than females with Brugada syndrome, and this is analysis we did in our patients, and we saw that we had 9% events in an overall population of 384 patients. The majority were male, and the number of events in males were almost 12%, while in females it was only 3%. Very interestingly, some studies have shown that, and these are 2 patients from Japan, that patients that had a Brugada ECG pattern and that they receive a castration because of a prostatic cancer, and after castration the ECG normalized in both patients. We are trying to set up a randomized trial, but we are lacking the control group. Let me show that, because this is a real email that I received. It says, I'm a 20-year-old male. I was a very healthy individual. I was on my duty about 10 p.m. I was talking on the phone when suddenly I lost my consciousness and hit the ground. Luckily, I was seen by my co-resident. He immediately hooked me to a cardiac monitor. When I got my consciousness, I could not remember what happened. Could you confirm, please, the diagnosis and tell me the steps I need to follow to protect my family? Okay. So first lesson, never be on duty alone, okay? So always have a co-resident with you. That's the most important issue, because this was the ECG that this guy had when he was recovered, and this is the electrocardiogram that this guy had with a very classical, typical type 1 ECG Brugada pattern, okay? So I'm using also this slide because it has been a long discussion whether asymptomatics are at risk or not, which is a discussion that I do not understand. Because this guy, when he was talking on the phone, he was asymptomatic. 1 second later, he was dead. So what do we mean by saying that the asymptomatics are not at risk? Every single patient that is had some symptom at some moment, 1 second before he was asymptomatic. So all the people that will have symptoms is previously asymptomatic. So there is no discussion whether the asymptomatics are at risk or not. I mean, some of them, of course, will develop arrhythmias and in this case, sudden death. This is a little bit what we published many years ago about symptomatic patients, at the moment of the diagnosis, previously asymptomatic patients, patients with syncope or patients with sudden death, that of course the incidence of events during follow-up is much higher in those patients that have been recovered from sudden cardiac death. About 50% of them will have a second event, major event, during the next years after the diagnosis. And you know that this is probably the biggest controversy ever in the field of electrophysiology, which is the use of electrophysiological testing in Brugada patients. Okay, we still believe that because our data are very clear that if you are inducible, you are at risk of having events. If you are non-inducible, the probability of events is very, very low. So we still continue to use inducibility in all our patients as a risk factor, although I know, and we can discuss that for hours, that many others have published that this is not the case. But here you see our data. If you are a male, if you have a syncope or sudden death, or if you are inducible, these four characteristics identify patients at risk of events during follow-up. Now, this is information about patients that did already receive an ICD, so that there is no discussion here because they already received an ICD, so they already were classified theoretically as high-risk patients. And you see that if the patient received an ICD 95 because of a previous sudden cardiac arrest, 46% will have a subsequent ventricular fibrillation terminated by the ICD. So there is no discussion on the endpoint here. We are not talking about syncope, we are not talking about arrhythmia, we are talking about ventricular fibrillation in the ICD. And you see that's about 50%. So there is no doubt everybody will accept that it is a super high risk population that need to be covered. It's a mean age of 40 years, people that has nothing else than the electrical disease. If the reason of the implanting is a syncope, and this was the case in 90, 26% will have ventricular fibrillation during the next years. So again, is a risk high enough to implant the defibrillators, is 1 in 4. So there is no discussion that the defibrillator, and here nobody I think in the world discusses that this is the case. Okay. Now let's see the patients that do not have any symptom prior to the implanting of the defibrillator, which were 107. So the overall event rate was 13% in follow-up. If you look at the basal ECG pattern, you see that the ECG was normal, which means that it was only abnormal after drug. We are talking about asymptomatic patient, normal basal ECG that has a positive test for ashmalin or flecainide, probably because of a family episode of sudden death or because he has a suspicious ECG. You see that 18 patients receive an ICD with these conditions, 0% had events during follow-up. So probably you should not implant asymptomatic patients with a basal normal ECG. So we are left now with 89 patients, and you see that we have now the overall percentage is 16% that will have events, and now we move to inducibility. In the patient is asymptomatic, has a basal abnormal ECG, so type 1 ECG is diagnosed without the need of drug, and is not inducible, 0% of events during follow-up. So this is why we use electrophysiological testing to risk stratify our patients with a basal abnormal ECG asymptomatic. We do the EP testing. If the EP testing is negative, we say the patient, you are at very low risk, you don't need to be implanted with the defibrillator. If he's positive, then it means that 14 out of 69, which is 20%, 1 out of 5 will have events during follow-up, and our suggestion to them is to implant the defibrillator because the risk in this case is high. This means around 20% of the asymptomatic patients. I say that because there is a lot of people saying you are implanting every single asymptomatic because you are inducing a lot of people. No, that's not true. We are, by using that, excluding a significant number of patients here, which is around 30%, and we are excluding almost 65% of the patients here because 65% of the patients asymptomatics are non-inducible. So the final number of asymptomatic patients that will be suggested to be implanted in our hands is not more than 20%, which is completely different if you cut it here. if you don't use CP testing, and you say, well, I know here, but I don't know what else to do when I'm here because I don't trust CP testing, it means that you are left probably with 70% of the population that has a doubt whether he has to be implanted or not, and you don't have any strong suggestion to say no, as we do when we have a negative testing. So I'm going to the end. The thing that worries us most are children, because there we have big problems in terms of management. If you decide to implant an ICD, this can be a terrible situation for them. So this is a father with this ECG. He has been recovered from sudden cardiac death. He's wearing a defibrillator. This is the son. Look at this electrocardiogram. It's terrible electrocardiogram. It's the worst electrocardiogram I've ever seen in a child. This child is asymptomatic. I've done already 3 EP studies on him. He's now 12 years of age. I've been following him since he was born, and all 3 EP studies have been negative. And I'm doing nothing. But each time I see him, I am 1 week without sleeping because I'm praying that someday he will become positive. Because if he will become positive on the EP study, then I will suggest implanting an ICD and I will start sleeping, you know? Because when you look at this electrocardiogram, it's really terrible, and his father already was recovered from sudden cardiac arrest. So, but still, I think we have to be consistent with what we believe, consistent with what we say, and be serious with all our suggestions to the people. And still, this guy, well, I will study him the next 2 or 3 years again, and I hope that when he will be 13 or 14, big enough, he will be positive, so we can implant him, and then I can relax. So this is the same for children, so very similar to what we see in adults, but with asymptomatic patients having very, very few events. But this is what can happen when you implant a child. So you have to be very careful, because it is a disaster. It is a big, big disaster. You have to end up with something like that, because this guy is going to grow up 20 centimeters every 2 years in the next years, and every 2 years you will have to change the device, the cables, everything, and it will be a complete disaster. So we have to be very, 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 very careful with that, and very serious in taking in consideration many other things. Talk to the family, explain them the reality of implanting and not implanting devices. And of course everything, I was putting this slide for you, Dr. Yahu, just to make sure that we understand that research is at the basis of everything. If we don't have research, we have nothing. Okay, and we have to try to understand everything through research. And research can be clinical research, but it has to be also basic research. And this is a very interesting issue that has been published some years ago by my good friend Dennis Kander, who unfortunately died some years ago of a myeloma. And he's very good physiologist and cardiologist. He developed this model of Brugada rat, and this Brugada rat had, these are the number of sodium channels in a normal rat. This is the sodium channels in a genetically manipulated rat with half of the channels. You see, this is the electrocardiogram of a normal rat. This is the electrocardiogram of a rat with this mutation. You see that it has a large QRS complex, probably more right bundle branch block, and this ST segment elevation that might simulate the Brugada pattern. So, and this has been used to study different aspects of the disease. So another thing which is more an historical thing, because we are on the history, is that you know that the disease is very highly prevalent in Southeast Asia. And there are some very funny stories there, like this one, which you see that the disease is called Bangunggot in Philippines, Lai Tai in Thailand, Pokuri in Japan, and Brugada syndrome in the rest of the world. And it says that in Thailand, the being of fear is the Fiam, or widow ghost, who comes to steal away the souls of young men. Some villagers think that Bangunggot appears in form of a huge and fat female demon that sits over men's face, suffocating them, causing agonal respiration and ultimately death. Some men defend themselves from Fiam by wearing lipstick at night so that the ghost mistakes them for a woman and leaves them alone. this is history. This is popular history. If this is what they do, and I've seen that in the villages, in some village in Thailand, the men wear lipstick at night, and this is true. This is not a joke. And if they do that, it's because the history shows, and the clever, popular history says that this must be there for centuries, and that the villages have learned and have tried to go through this sudden death at night of young men, which fits perfectly with what Brugada syndrome produces. And this is my last slide. You see here you have families. You have families of singers, of actors, of killers, and researchers. And you can decide which one is what. You know, you can decide whether this one are theater and this one are killers or this one are whatever. So these are the three Brugada brothers, myself, Pedro, and Ramon in the garden of our family in Banyoles in Spain. Thank you.
With regards to syncope, do you approach all syncope episodes the same, or syncope in a young man, a 20-year-old, that's sudden and sounds arrhythmic, versus syncope in a 60-year-old that sounds vasovagal, perhaps? Is all syncope the same?
No, when we are dealing with syncopes in Brugada patients, of course, a Brugada patient can have a vasovagal syncope, and a Brugada patient can have any other type of syncope. So we have to make sure that we classify correctly the syncope. I mean, the fact that the patient would have a Brugada type 1 ECG, for instance, of course, will make you very cautious in thinking that the syncope can be related to Brugada, but the Brugada can have a Wolff-Parkinson White, or can have a vasovagal syncope, or can have a heart infarct. So there is no doubt about it. So we try to work out the syncope as in any other condition. Let me go in both ways. So you have the patient with a type 1 ECG and has a syncope. The workout will be to link the syncope to the Brugada condition and to exclude any other cause of syncope, because then the consequences in terms of management will be, if you finally decide that the syncope is related to Brugada, you have to suggest an ICD, that's for sure, because you are in this mid to high risk group. But let me go the other way around, the patient that has a syncope and does not have the Brugada. So Brugada should be in the differential diagnosis of a syncope if the syncope looks cardiogenic in origin. So you have a syncope, and this syncope looks cardiogenic, but you don't have any condition suggesting a cardiac disease, you should think very carefully whether you should do an Eichmann or a Fleckenstein test in this patient to make sure that you exclude a Brugada ECG as the cause of a syncope. So you have to go both sides.
So if the syncope doesn't sound absolutely cardiogenic, do you see a role for EP study in that syncope?
Absolutely, as in any other syncope. If the syncope does not look cardiogenic to me or related to the Brugada condition, I would work out the syncope as any other syncope. I will do everything I need. Even I will implant a reveal if needed, or a loop recorder, whatever, just to make sure that I understand it before. If I am convinced that the syncope is cardiogenic and related to Brugada, then of course I will implant an ICD.
Mike, thank you for the very nice
Thank
presentation. Really, it's nothing nicer than hearing it from the horse's mouth. But anyway, the symptomatic and symptomatic syncope, no syncope, is there an overlap in all this categorization, or is it really as sharp as this? This is my first part. Second part is exercise testing has got any benefit in Brugada syndrome? Thank you so much.
Okay, I will start with the last one. No, Brugada exercise testing does not. We don't think it has any role. Why? Because in fact, when you want to normalize Brugada ECG, you give isoproterenol or you exercise the guy. In fact, we have a big discussion with some societies around the world which tend to be very conservative and say a Brugada patient cannot exercise, and we say yes, he can. And then they say no, he cannot. You say why not? We've never seen a Brugada patient dying suddenly during the sport.
This is related to athletes and things like that.
Right. So, but it's true that you can argue there, and there are two arguments. One argument is that, of course, and I haven't shown that, but the temperature dependency of the Brugada ECG pattern and symptoms. We know that the higher the temperature with fever, etc., there is a very, very high risk factor for events. So we have to be very careful with fever and Brugada. So the people arguing that the people should not sport is because they say that the body temperature will rise because of the sport, which is probably true within certain limits. Second, because at the end of the sports or in the recovery phase, you have a vagal reaction, and this vagal reaction could be at the same time producing some increase in the ECG pattern and symptoms, which might be true also theoretically, but we have not seen it in practice. So we are not stopping from sporting the people with the Brugada pattern. Of course, we ask them not to do sports that might harm them if they have a syncope. Okay, so can I do, I don't know, subaquatic, I don't know what? We say no. Can I jump from a plane? You better don't, okay? But let's say regular sporting, we are not stopping that. In terms of how sharp are the definitions, well, as sharp as it can be, because we have been discussing what is a syncope. You know, we still have a lot of doubts in many syncopes of unknown origin that we don't know, and you talk to the guy and then you try to understand whether it was some symptoms before or not, whether this is a recurrent syncope in different situations, and you try to understand, but still it's very difficult, and many times we end up with a loop recorder because you don't know, and then when you look, of course, it was a vasovagal syncope, you can see it, but you know, it has to be as sharp as it can, but with all the question marks that the conditions produce.
Thank you for this wonderful presentation. My question is going to be very naive and from a researcher perspective. Well, so far to reverse the Brugada syndrome, what you do is you implement people with pacemakers, right? The idea for kids or for patients is to have a drug that will basically reverse the Brugada syndrome, right? So my question is, on your animal model, if you take cells from those animal models, isolate them, and separate them into two groups, by doing patch clamping, will you basically be able to say this cell is coming from a patient that has Brugada syndrome or not? If yes, could you basically work with a drug that modifies the calcium channel properties to make the cell more excitable?
We know pharmacologically, what we know about Brugada syndrome is that you have, in phase 1 of the action potential, you have a premature closing of the sodium channel, so that gives rise to an unbalance between the sodium that is getting into the cell and the potassium that starts to leave the serum through ITO. So you have a relative increase in ITO. So if you could compensate this relative increase in ITO, probably you would normalize everything. So to do that, you need something that increases the sodium channel in the phase 1 of the action potential. We don't have this. Or you can block the ITO, but then you will have a reduced ITO and reduced sodium channel. I'm not sure that the relative balance will be okay, but you will be on a blocking part of the channels itself. Now, we know that quinidine is working, because quinidine is clinically working. When you have patients with electrical storms, a lot of arrhythmias, you give quinidine, you usually have a good result. Good result meaning that you don't have storms anymore. In many patients you don't have any arrhythmia. In others you might have, but limited number of arrhythmias. So that's why there is also a discussion worldwide whether we should be offering quinidine instead of ICDs. And I say, well, quinidine can help the patient that has storms, but I'm not sure it's the first line therapy in patients that are at risk, because they might still have some ventricular fibrillation and dies out. Now, can we have other drugs that might be useful? Well, you know that now ranolazine is being studied. Ranolazine is an inhibitor of the light current sodium current. we'll have to see whether this might. My feeling is that this should increase Brugada. This should produce more Brugada. But probably we'll be able to find enhancers of the late sodium current that might counteract the effect of the mutation. But this is still everything on the experimental level, and I don't know of any other advance in this field.
So just to go back to the exposition. So if you have two cells that are coming from different samples, right? You can tell that this cell is coming from a patient that has Brugada, right? You can check if the exposition is different.
Yes. Yes, you have, yeah, sure.
Right. So
You
you
have,
can play with the channels, either potential channel or sodium channels, to basically mimic what you get on the Brugada syndrome and vice versa.
right. You should be able to do that. The model, no, one second, eh? The model is not an exact model for Brugada. The model is 50% of the sodium channels are out. That's all we have. That's all we have. It's a different mechanistic. So the final result may be the same, but mechanistically speaking, it's different.
I have a question. Basically, we are experiencing an increasing number of Brugada pattern asymptomatic patients, not only in Qatar but in the Gulf region. One of the dilemmas we face with regarding taking medication, they are asymptomatic, but for a reason or another, they could take an over-the-counter medication. Or I know there is a long list of medication those patients should not
Yeah.
take. But how we could know that these group of patients are lower risk than or risk stratify them?
I would not make differences in terms of who can or who cannot take medication. I think that if you have the suspicion that the patient has a Brugada, you should provide them with a list of forbidden drugs, and this can be very easily found and is updated every week if needed in brugadadrugs.com. Okay, brugadadrugs.com. You can find there the list. You can find there an updated. We look at every single. There is a group of people around the world. We are looking at every single publication related to drugs, and then we make a consensus for every drug to see whether we put it in the completely forbidden, be aware drug or allowed drug. So I would not play with the relative risk of the patient, but I would say, look, everybody that has a suspicion or diagnosis or suspicion of the diagnosis, I would certainly ask him not to use these drugs.
I have a question. You said if the patient is asymptomatic and normally based on ECG, what do you mean by these patients? I mean,
This is the son of a Brugada patient. Okay, so this is the son of a Brugada patient. The father has a Brugada. The son has a normal ECG. You don't have genetics, because if you have genetics, that's fine. You have the genetics of the father with the mutation. You look at the genetics of the son. If the son is negative, it's ready. Okay, but you don't have the genetics, so it's a 70% that has no mutation identified so far. But the family wants to know whether the child has or has not a child or no child, whatever, a family member, and then you do a national test or program, and it's positive. Okay, then the next question is, how do you know that basally speaking is negative? How many ECGs do you have to do to be sure that he's negative? And of course I don't have this answer, and that's why I put myself the question. So what we suggest is that if the ECG is completely normal, there is no suspicion at all, we just ask to do one ECG every year. If the ECG has some suspicion, then what we ask is that in case of fever, they should have an ECG done, because this will be the more powerful indicator, okay? And see what happens. But I know that there's some gray zone, which is if the ECG is spontaneously changing, how do you know that he's not having a positive ECG tomorrow? I don't know, of course.
Last question.
Thank you, sir. For survivors of sudden cardiac death, which is unexplained, is it justified to subject such patients to marine testing?
I cannot hear you very well.
For survivors of sudden cardiac death,
Yes.
which is unexplained, is it justified to expose such patients to for marine testing?
So survivors of sudden cardiac death
Yes.
that have not been diagnosed as Brugada,
Yes.
okay? So the question is whether we should.
A clear reason for that. We don't have clear cause of this sudden cardiac death.
Well, this is the overall workup that you have to do on the survivor and on the family. So if the survivor has some signs that might have a channelopathy, of course you have to exclude that he's not a ischemic patient or myocardiopathic patient. If you have accrued any structural heart disease, then of course you have to go through all the workout to understand whether he has or he has not a channelopathy. You have to realize that at the end, still, even with all the tests we have, 10% of the population, we will not know why he did the cardiac arrest. Now, very interesting is to see at the family, because sometimes the answer comes from the family. You have to look at different members of the family, first degree relative, trying to see whether they have some ECG abnormality. You also have to make sure that you exclude also the catecholaminergic polymorphic VT, which is one of the most prevalent diseases in normal hearts, normal ECG. I don't know whether this answers your question or not.
Thank you very much, Professor.